طيب مرحب بكم. This is going to be the second section and the last of pericardial diseases. طيب if we look together here, this might be a subcostal view, and you see that there are some kind of tissue filling here, right? Extracardiac or epicardiac and pericardial. So any suggestion about what this might be? Hmm. Yani this is up until here is the myocardium. Then we are seeing tissue here. Then we are seeing a small linear structure, and then we are seeing a density here. So this is what I want you to be familiar with. This is fat, okay? And around the heart, yani, we have two pools of fat. One is immediately adherent to the myocardium, and this is epicardial fat. Then you have the parietal pericardium, and overlying the parietal pericardium is pericardial fat. So if you look in here, that's going to be like if you take the wall this way, this is the wall. Immediately above it is epicardial fat, okay? And above the epicardial fat, you're going to find the pericardial fat, and this is going to be the parietal pericardium, okay? So this is what we see. Like, what about this one here? What are we seeing here? This is pericardial effusion, and something here. What could that be? What could that be? And that could be fat. Yes, it could be fat. لكنه in this case, this is a hematoma. So this is both pericardial effusion and hematoma. Okay, you can have them both, or you can have each one separately. What about this one here? This is large pericardial effusion. But what characterizes this pericardial effusion is what? Something very impressive about this pericardial effusion, which is what?
Inoculated with fibrinous band.
Exactly. These are fibrous bands, okay? And we have said it before. Fibrous bands like this means that the effusion is what? Is exudate, and a very dense exudate. So usually this takes place in condition like malignancies, infections, and stuff like that. Inflammatory kind of pericardial effusion, infection, pericardial effusion, or malignancy related pericardial effusion. Okay. طيب, if you focus carefully here, you are gonna find some kind of bubbles, right? So you see the bubbles are filling in here. You see the bubbles? From where these bubbles come? Uh-huh. Anybody has any suggestion or any idea? From where do we get bubbles inside the pericardium? Inside the pericardial space. There is pericardial effusion for sure, but there are bubbles, dense bubbles. Mhm. This is, they do it when they are doing pericardiocentesis. So if you are directing your needle toward the precardial space and you are getting blood, okay? So this blood can be from the cavity or can be from the precardium, yes? So how to make sure that your needle is in the pericardium and not inside the chamber cavity? You use the same needle and you inject uh, agitated saline, or sorry, you inject bubbles, okay? Just bubbles. Yani if you push just normal saline, that's okay. And that's gonna fill this space without appearing inside the cavity, meaning that you are safe to aspirate because your needle is just in this space and not inside the chamber, not inside the LV or RV cavity. So this is important test sometimes if you need to be sure. If you do completely echo guidance precardiocentesis, probably you are gonna see the needle coming through and you don't have to do that. Like if you go like you just use echo to direct your needle and then the echo is away and you aspirate blood, you don't know, are you in the precardial space proper or you have gone deeper into the cavity? You can inject this saline and you see the bubbles filling into the precardial space without going into the cavity. So you are in the precardial space. What is this here? What are you seeing? Mhm. What we are seeing here is what? We are seeing the needle coming through. Yes. And this is echo-guided pericardiocentesis. So what you do with the echo-guided pericardiocentesis, first you choose the window of the needle. I mean, where are you gonna push the needle? Suprasternal, substernal, or parasternal, or apical window. That's according to the largest pool of fluid. Okay. And then you are gonna, by echo, see the needle coming through the space. Okay. So as the needle advances, you are seeing it by echo. So we are seeing here the needle coming through. So as soon as it reach here, we're gonna stop and aspirate. So that is precardial space, and this is echo-guided pericardiocentesis. Imagine how echo has made this procedure quite safe. If you go blind, you might go into the cavity, might pierce through the cavity, you might aspirate blood from the cavity, you might augment the shock state the patient already having, and all of that, okay? So this is echo-guided precardiocentesis type. What are we seeing here? This is again a subcostal window, and we are seeing both precardial effusion and what is this? This is hematoma. Okay, precardial effusion and hematoma. Good. Right. So what are we seeing here? This is a subcostal window. Okay. I need somebody to guess. What are we seeing here? Okay, what are we seeing? You remember the first presentation on precardial disease, we have discussed how we distinguish between precardial effusion and pleural effusion. And this distinction is not always easy. And we have agreed on two landmarks. One is the descending aorta in the parasternal lung axis, and also in the apical. Other is the lung tissue. If you see the lung tissue in a pool of fluid, that is precardial effusion, that is pleural effusion. طيب الآن, what is this? This fluid. You see I'm pointing to this fluid. What about this fluid? This fluid. What is it? Is it pleural effusion or precardial effusion?
No, this is out of pericardial space. Most likely
Exactly.
pleural.
Pleural effusion. Why? Because if you look at the descending aorta, which is here, this comes lateral, okay, and extend way beyond the AV junction. This is one thing. The other thing is that this is the lung tissue. This one is the lung tissue. Okay? So this is pleural effusion. Imagine how easy to conflate these two together. And you might look at it and you say, oh, this is large pericardial effusion. There is no large pericardial effusion. This is pleural effusion. But is there any pericardial effusion? Yes, there is a small rim. If you see here, this is a small here and here. Small rim of pericardial effusion. Okay? That is a small rim of pericardial effusion. So we have sizable left-sided pleural effusion and we have a small pericardial effusion. Do we have anything else? If I just take this, erase all of this. Okay. What is this echolucency here? Any guess?
Pleura.
The pleura, not the pleura. Because the pleura is supposed to come here and on here. This is left and this is right. But here, closer to the liver, which is here, the liver is somewhere here, we are seeing echolucency. And if you focus carefully, you are gonna find that this echolucency, there is something like echodense traversing that echolucency. So it looks like this, echolucency and echodensity traversing it this way. This is the fingerprint of ascites by echo. This is ascitic fluid. So how do we see ascitic fluid? We see it from the subcostal window when we are seeing echolucency with echodensity crossing it. And this echodensity is the ligamentum falciform of the liver. I might show a better example. Type, look here. Anybody tell me what it is? Any one of you? Here. What are we seeing? Pleural effusion or pericardial effusion?
Both.
Huh? Uh-huh.
I think both of them.
Okay. Lakin, what is the biggest?
A plural.
Exactly. This is all pleural effusion. And maybe the pericardial effusion is this just a small rim. But all of this is pleural effusion. And this is the lung tissue. Okay. This is the lung tissue. And again, if you look at the descending aorta here, this is away from it. Okay. Type now here, look here. Again, we are seeing a small pericardial effusion. Look at this one here. There is echolucency and there is this ligament. This ligament is a very important landmark for ascites, ligamentum falciform. Okay, so this one, wherever you find this one in the subcostal window with the ligamentum falciform, you can report there is an evidence of ascitic fluid. Okay, and this is hematoma. Okay, this is hematoma. Okay, now what about here? This is chest x-ray, right? Chest x-ray. But we are seeing some here, echolucency, right? We are seeing echolucency. What can that be?
Pneumopericardium.
Exactly. Pneumopericardium. Very good. And this is extreme example of pneumopericardium or even tension pneumopericardium. You see air is filling the pericardial space. Air is filling the pericardial space. And here you can see it by echo, air in the pericardial space. So, what are the causes of pneumopericardium? What makes air inside the pericardial space? What if I have trauma? If I have trauma, it can bring air from wherever inside the pericardial space. Okay? So complicating trauma. Other thing, if you have fistula between air carrying structure and the pericardium. And if you have esophageal-pericardial fistula, bronchopericardial fistula, it's gonna put air in the pericardial space, right? Sometimes if you have air generating organism, infection by air generating organism, you might also have this one. And also iatrogenically, yani if you do pericardiocentesis, you might introduce air there, okay? As a complication of pericardiocentesis, okay? When your system is not well sealed and things like that. Okay? So trauma is important. Fistula, infection, iatrogenic. Okay, this is pneumopericardium. A patient has cancer with mets to the heart. Which of the following is true? The mets will most likely be intracavitary mass, i.e., it seeds in the endocardium. The mets has predilection to the pericardium. The mets will be complicated by transudative pericardial effusion. The mets are most likely from a melanoma. Which one is true? Any guess?
The melanoma is one of the causes of pericardial effusion. In 30% of the patient, it may be unnoticed and lately can be found.
Okay, very good. Very good. And melanoma, just to add another point, melanoma has a predilection to the heart. It preferentially metastasizes to the heart. Okay? يعني in the affinity to seeds into the heart. قبل الليفر والبونز وكده. Okay? لكن still, the myths are most commonly coming not from melanoma, but from, because melanoma is extremely rare tumor compared to carcinoma of the
أيوة.
bronch, the breast and stuff like that. So if I tell you, statistically speaking, you are more likely to see mets on the heart coming from the most common malignancies rather than rare malignancies like melanoma. But if you have a patient with melanoma, his chance of having heart mets is extremely high compared to other malignancies. Okay? So D is not going to be right. So will the mets be intracavitary or it's going to be pericardium? Will the effusion be transudative or exudative? And we have mentioned that. Is going to be transudative or exudative? Malignant pericardial effusion are always exudative وhemorrhagic كمان. Okay? A transitive is like يعني viral pericarditis or connective tissue disease, stuff like that. لكن a transitive is for infection, high protein content of infection of malignancies and inflammation. Okay? So usually the mets of malignancy is hemorrhagic, so it's not transitive, it is exudative. So we are between A and B. Will the mets go intracavitary or seeds on pericardium? Usually they seeds or they seed on the pericardium. Yes. طبعا انت you can have mets to the heart. Where in particular? You can have these mets on the pericardium or into the myocardium or into the endocardium inside the chamber cavity. For the most common site or location of METs is the pericardium, not the myocardium and not the endocardium. Okay? So the right answer here is going to be B. Good? It's going to be B.
Okay.
Now here are METs to the pericardium, as you see here. These are METs, dense METs seeding into the pericardium, making it kind of rough and corrugated. And this is seeding from melanoma. These black spots are melanoma METs. Okay. Type. This chest X-ray shows what? Hiatus hernia, artifact, pericardial calcification, pericardial cyst, raised hemidiaphragm. Which one? You look at the heart here, this is the heart contour or silhouette. It's like this. But we are going to see this density here at the right cardiophrenic. Okay?
Cyst is most likely cyst.
Yes, this is most likely cyst. This is the typical location of pericardial cyst. And the pericardial cyst is simply encysted chronic pericardial effusion. Okay? And this is the typical location. So you are going to find it around the right atrium. Yes? Most common location. And it is so impressive on chest X-ray. You see it this way. Okay? So this is pericardial cyst. And again, this is pericardial cyst. Yes. If it's a hiatus hernia, you're going to see it more on this side, and it is going to be air containing, not as dense as this one. So this is pericardial cyst. And here is the pericardial cyst in chest X-ray, in CT, you see this is a large one compressing on the right atrium and part of the RV, okay, a large pericardial cyst. And here in the echo, we see this is a small pericardial cyst. See where the typical location of pericardial cyst around the right atrium, okay? The right costophrenic angle. So it's here. This is the right costophrenic angle here. So this is a small cyst, and this is large cyst and compressive. You see the right atrium, how compressed it is here, right atrium, okay? So what do we do for pericardial cyst? We leave them alone unless they trouble us, okay? Don't trouble till trouble troubles you, okay? فهنا إذا كان compressive by echo or symptomatically a patient is having a problem relating to this, then we have to do surgical excision, okay? Good. And this is a pericardial cyst, remove that cardiac surgery. Okay. Good. شباب متابعين معي كويس؟ أي شباب؟
It's okay, boss.
تمام. طيب, this is a 45-year-old gentleman presented with the following sign. See images. See this one and see this one. And tell me, what are we seeing here and what are we seeing here in echo? And the question is about what's the next course of action. Send for surgery, order cardiac CT, start the patient on a short course of steroid, follow up in 6 months. Well, of course, that's not enough to answer this question. You need full clinical data about this patient. But let's assume you just have this one, which is sort of clinical sign, and this one, which is echo sign. So this clinical sign is about, look at inspiration. During inspiration, and look at the RA pressure represented by this line. During inspiration, what happens to the pressure? It increases. And during expiration, which is here, it decreases. That's exactly the opposite to the physiological happening. In normal physiology, usually during inspiration, the pressure, the right atrium, I mean the right side sucks more blood, so the venous pressure drops during inspiration. But here we are seeing that during inspiration, the pressure increases. You see it here? Yeah, the pressure increases during inspiration. So this is what? This is a clinical sign which is called increase in the venous pressure, jugular venous pressure during inspiration. What is this sign? Cosmo. Yes, it's cosmos. And what are we seeing in echo? Look at the septum. Look at the septum. See how it goes? Yeah, see. Once you see a septum going this way, this is called septal bounce. Septal bounce, and it is very important sign of constriction. So clinically, we have cosmal sign. Echocardiography, we have septal bounce. So this is most likely constrictive pericarditis. So what are we gonna do for a patient of constrictive pericarditis? Send for surgery, order cardiac CT, start on steroids, or follow up in 6 months. I'm going to choose this one, cardiac CT. But why cardiac CT? Because I want to send the patient for surgery. Sending patient for surgery is the second right answer. But if you have sent for surgery and order cardiac CT, choose order cardiac CT first. Why? Because before we send patient to surgery, we need to see the state of the pericardium in preparation for pericardial stripping. The surgeon is going to be curious to know how tough the pericardium is, how calcified, and how much the calcification on the pericardium might be invading the muscle. So he want to plan for his surgery. And this is done through cardiac CT. Okay? So cardiac CT. Good. We have this 54-year-old male, no past history of note, currently asymptomatic. He did his chest X-ray as part of employment checkup. His physical exam is unremarkable. What is the next step? So we did this chest X-ray as part of medical checkup, and that's what we see. So are you going to reassure, do echo, do cardiac CT, follow up chest X-ray after 6 months? That depends on what you read in this chest X-ray. So what do you see in this chest X-ray?
There is pericardial calcification, so we'll order for CT, cardiac CT.
Exactly. So we have pericardial calcification. It's kind of eggshell calcification all around the pericardium, you see? That is pericardial calcification. Okay, so if I have pericardial calcification, you are gonna, of course, no, you won't reassure and you won't just send him home and see him in 6 months. You either have to do echo or cardiac CT. الدكتورة قالت maybe cardiac CT. Any other opinions? طيب, look at this patient. This patient was having a clinical sign of constriction. And we did echo and we have found septal bounce. So probably we have confirmed constriction. Then we have to go for cardiac CT. But based on calcification alone, you don't go to cardiac CT. Maybe you go to cardiac CT, yes, it's not wrong answer, but hierarchically, you go for echo first because this is pericardial calcification. Cardiac CT is going to show me the extent of pericardial calcification better than chest X-ray. But this is the information I'm looking for? Or am I looking for, is this patient having constrictive pericarditis by echo or not? Yani he is not clinically symptomatic, but echo might reveal the physiology of constriction. And in this case, I might operate even in the absence of symptoms. If the echo, تذكروا لما اتكلمنا عن التامبونات قلنا if you have echo showing large pericardial effusion which is compressive by echo, but the patient is clinically stable, are you going to wait or aspirate? And we agreed that under good circumstances, you better go proactively than reactively. Better go now than wait for cardiogenic shock and stuff like that to aspirate the fluid. The same applies here. If I do echo and the echo has showed me that there is a the pathology of constriction has been demonstrated in echo, I might operate. Okay? And in this case, I will order cardiac CT before surgery. But here the right answer is going to be echo. Okay? So if you see any patient who is asymptomatic, but incidentally you find pericardial calcification, you have to order echo. Okay? And this is all pericardial calcification, and here also pericardial calcification, and this is the lateral X-ray showing pericardial calcification. And by the way, lateral X-ray is better than APMPA orientation in depicting and discerning calcification. Okay? Lateral is better than this one. In the lateral, you see calcification, pericardial calcification better. Type, if you look here, this is also what pericardial calcification. Is it also pericardial calcification here? This one. Is it pericardial calcification or something else? This one. When the patient is having an ICD, okay, and how do I know this is an ICD? Because there are coils, you see. It's not so clear here, but you also have to know which device is this based on chest X-ray. Is it pacemaker or ICD or ICD CRT? Okay. طيب, this is a calcification but of apical aneurysm. This is apical aneurysm and calcification. And if you look here, you feel that the geometry of the chamber is distorted. There is a sudden outpouching. So this is the aneurysm, and it is overlaid with calcification. So this is not pericardial calcification, but apical aneurysmal calcification. Okay? Type, what type of calcification do you see in this chest X-ray here? This one here. What is this calcification? Any guess?
This is coronary artery.
Sometimes yes, ممكن يجي الكورونال artery كده. What other guess? هي وتقريبا دي اللوكيشن بتاعت الميترال valve. So if I tell you that the mitral valve is in
Mitral annular calcification.
MAC, okay, MAC. So by the chest X-ray you can see calcification in the heart. زي ما قالت الدكتورة sometime coronary calcification, MAC, aortic valve calcification, apical aneurysm calcification, or pericardial calcification. So you have to know exactly how you spot out pericardial calcification and you differentiate it from other calcium densities on the heart. Okay? And this is pericardial calcification on fluoro. Yes, very dense calcification on fluoro. So you can see the calcium or the calcification and the pericardial calcification. You can see it in chest X-ray بالذات lateral chest X-ray. You can see it in cardiac CT the best way possible. And you can also see it in fluoroscopy. طيب, can you see it in echo? Yes, you can. But echo is not so reliable in detecting precardial thickness and precardial calcification. Okay? طيب, if we look here, this one, look here, this one is fat. This is fat. This is epicardial fat. And this one above is precardial fat. And this is what? This one here is the precardial. Okay? This is the precardium. So we measure the thickness of the precardium here. And this is precardial calcification, which is eggshell calcification. And you see how much it's going inside the muscle here at the vicinity of AV junction. And this is important piece of information for the surgeon, because when he comes in here, he's going to have a trouble, yeah? So he has to know what to do here. Good? But these are what? What are we seeing here? This calcification relates to the coronaries, CERC and RCA, okay? CERC and RCA. So in cardiac CT, you can know about the precardium the best way possible. You can know the thickness, the calcification, the extent of calcification, the depth of calcification, all of that, okay? But as far as the hemodynamics of constriction, echo is the way to go. Echo. Hemodynamics of constriction, echo. The state of the precardium, cardiac CT. And we do them both. So if we have the right patient, or we stumble upon incidental precardial effusion, the first thing we do is echo to demonstrate hemodynamics of constriction. Then if we plan for surgery, we do cardiac CT to see the thickness and calcification of the precardium in preparation for surgery. Okay? Type. A 55-year-old man, previous history of cabbage 5 years ago, notes worsening dyspnea on exertion and pedal edema. On exam, he is noted to have elevated JVP. That increases with inspiration. So that he speaks about cosmal sign. And there is a loud early diastolic sound. And this speaks about pericardial knock. So he's most likely to have which of the following? Mitral stenosis, ischemic cardiomyopathy, constrictive pericarditis, restrictive cardiomyopathy, post-cardiotomy syndrome. So this is easy. And post-cabbage. We know that the causes of constriction are many, but one of the most important is post-cardiac surgery. Post-cardiac surgery. So post-cabbage or valve surgery, stuff like that, you get constriction over time, okay? And here are signs of constriction: elevated JVP, cosmal sign, precardial knock. So this is constrictive pericarditis. Causes of constrictive pericarditis is idiopathic in 42%, cardiac surgery 29%, radiation, renal failure, connective tissue disease, and tuberculosis. In some other countries, tuberculosis may come number 1 in a cause of as a cause of constriction, but this is globally speaking. Okay, globally speaking, idiopathic and cardiac surgery constitute more than 50% of the cases of constriction. Okay. And here is, look, this is a pericardial thickening and calcification, and this is pericardial fibrosis. Okay, pericardial fibrosis. Usually thickness, if it is less than 2, so unlikely to have constriction. If it is 4, that is so possible to have constriction. If it is more than 6 millimeter, high specificity of constriction. But I want to remind you about this one. 18% with normal thickness. يعني can you have constrictive pathology with normal thickness of the precardium? The answer is yes. In 18%, this is according to Mayo Clinic data, 18% of the total number of patients diagnosed with constrictive pericarditis showed normal thickness precardium. So normal thickness precardium will not preclude constriction. Okay, good. Come on. Now, what am I showing you here? This is a famous schematic about the interventricular interdependence in tamponade and in constriction. So what I want you to see in here is, let's take this face, and I want you to focus carefully with me here. Okay, during inspiration, what happens? During inspiration, we have a decreased pressure on the right side and increased flow to the right side. Increased flow to the right side. And look at the septum where it goes. It goes leftward. It goes leftward. Okay? So what happens here? The forward pressure, the forward blood from the liver is going to increase, and the forward flow is this one, S and D. So S and D are here. Okay? And the tricuspid inflow is gonna be robust. حاجة كده ماكنة يعني ها. Now, if we take during expiration, the septum is going to flip rightward. It's going to go rightward. So what is gonna happen here? It's gonna compromise the right side and increase the pressure on the right side. How this translates in hemodynamics? When you see the hepatic Doppler, see the forward flow? The forward flow is going to kind of decrease a little bit. But most importantly, you are having a reversal here, which is bigger than in here. And I'm going to explain this later. And the other thing is that, look at the tricuspid inflow during expiration and compare it to during inspiration. It's going to decrease. Yes? So during inspiration, we have more of tricuspid inflow and less of backward flow in the liver. During expiration, we have less of tricuspid inflow and more of backflow into the liver. طيب, let's look at the left side of the heart. During inspiration, the septum goes leftward, so this minimizes the LV cavity. And also during inspiration, the flow that comes through the pulmonary vein is lower because during inspiration, the lungs sequester the blood. So the blood going through the pulmonary veins is going to decrease. So the pressure is going to drop here because of low flow of the blood. And also the septum is going to minimize the cavity further. That will translate in what? In decrease in the mitral inflow. Mitral inflow is going to decrease. Now let's see during expiration. During expiration, the lung is deflated. So this pushes more blood here. And also the septum moves rightward. So we have more blood here. So that translates into an increase in the flow across the mitral valve. So if you compare the flow across the mitral valve in inspiration and expiration, you're going to find it this way. This is in inspiration and this is in expiration. Okay? So this describes the interventricular interdependence. Exaggerated interventricular interdependence. Okay? So this is how we are going to explain the science and the hemodynamics of constriction. طيب يا شباب كده فهمتوها؟ ها؟ معايا يا شباب؟ آه شباب انتم متابعين ولا انا صوتي اختفى؟
ايوه يا بوس، كويس كويس ماشي.
كويس كويس.
بس
طيب
عاملين ميوت عشان تفتح اللي تخش في السيستم وتعمل تيكو.
اوكي اوكي
اوكي.
تمام تمام. طيب let's take this question. A 48-year-old gentleman has radiotherapy for mediastinal tumor 3 years ago. Presented with lower limb and abdominal swelling. Careful echo analysis revealed the following data. Apparently normal pericardium with no calcification. Septal bounce in 5 beats. Medial E prime is 16 and lateral E prime is 10. The patient was in AF, so the hepatic reversal was not demonstrated. Ventricular contour is normal. There is mildly dilated atria. Based on the clinical and echo data, the next course of action is order invasive hemodynamics to confirm constriction, order cardiac CT in preparation for surgical precardial stripping, follow up with echo in 6 months, order chest X-ray, EP, and lateral, 4 weeks course of steroid and follow up for clinical and echo improvement. Okay?
difficult يا بوس.
Difficult I know، لكن خلينا نعمل لها يعني
exclusion واحد واحد.
fold it into its clinical and echo ingredients. This patient is having a history of radiotherapy for mediastinal tumor. So that brings me to the etiology of constriction, which is radiation.
Yes.
He had abdominal and lower limb edema or swelling, abdominal swelling, ascites, lower limb edema. So these are signs of constriction. Now, when we come here, we find that the pericardium looks normal in echo, lacking the medial E prime is faster than the lateral E prime. And we also found that there is septal bounce. So these are the only 2 positive signs. Hepatic flow reversal cannot be demonstrated. Ventricular contour is normal. Pericardium looks normal. So is that enough to diagnose constriction? Or if you say no, meaning that you are going to order invasive hemodynamics to confirm constriction. Of course, you are not going to order AP chest X-ray and you won't put the patient on 4 weeks course of steroids because this seems like a chronic condition and it relates to radiotherapy, okay? Not to any kind of inflammation. So we are between B and A, B, and C. طيب. If this is a sign of constriction, septal bounce, yes. Medial E prime 16 and lateral is 10. Is it a sign of constriction? Yes. So these 2 signs of constriction are enough to diagnose constriction in this patient. So this patient is having constrictive pericarditis, and we have just to go for B, order cardiac CT in preparation for surgical pericardial stripping. Like, I'm going to show you this one, don't worry. But look at this sign. This is the medial E prime velocity, which is 17. And this is the lateral E prime velocity, which is 12. Before we go into the question, is that normal? To have a septal?
No, of course.
It's not normal. What is the normal? The normal is usually lateral E prime is
more than the medial.
more than the septal E prime. ليه؟ لأنه lateral E prime moves better لأنها free. لكن الميديال, look at the medial segment هنا, is connected to the cardiac skeleton, so seems to be more restricted by the tissue around. So usually the lateral E prime, or physiologically the lateral E prime, is faster than the medial E prime. So now I have exactly the opposite. The septal E prime faster than the lateral E prime. So what is this? This echo sign is exclusive for constrictive pericarditis. It is called annulus paradoxus. It leads to overestimation of the pulmonary capillary wedge pressure. Its validity is lost in AF, shows as lateral wall decreases strain and strain rate. طيب, first of all, does it lose its validity in AF? No. لأنه this
No,
is E
no.
prime, E prime, and this one الثانية اسمها A prime. A prime is lost in AF, but E prime is not lost in AF. So it's still valid in AF. طيب, is it called annulus paradoxus? هل اسمها annulus paradoxus؟ ممكن. Maybe. طيب, is it exclusive for constrictive pericarditis? Not necessarily. ليه؟ لأنه إذا كان مثلا إذا عندي infarction هنا يا شباب, lateral wall infarction, will this segment be slower than this segment? Yes. And إحنا بنتكلم عن a normal condition in which there is no constriction and there is no infarction and there is normal mobility of all segments. في الحالة دي lateral E prime is faster than the septal E prime. But what makes the septal E prime faster than the lateral E prime? Constriction and lateral infarction. يبقى it is not exclusive of constriction. So the right answer here is this one. I'm going to show you why. This is a strain, by the way, okay? This is strain. Look at the strain, the polar map here, which represent the deformation of the 17 segments. Where is the problem? The problem here, this one, this part has low strain, okay? The strain is lower in this part. Why it's lower? Because this is the lateral segment. And the lateral segments is just underlying the pericardium. That's why the strain on the lateral segments is gonna slow down. And look about the changes post-pericardiectomy. The lateral strain has recovered to a great extent after pericardiectomy. Okay? So you can also diagnose, or strain can help in the diagnosis of constrictive pericarditis. Look at this one here. Okay? If we look here, this is a patient who is having early form of constriction. If we look at the lateral E prime, it is 18. The medial E prime is 14. Does this go with constriction? لاحظوا, a lateral E prime, which is this, is 18. The medial E prime, which is this, is 14. Does that go with constriction?
No.
No. Very good.
No.
No.
Improving. بص.
ايوه, هو ده ما عمل بريكارديوكتومي. لا. لكن انا بقول لك هنا that doesn't go with constriction.
No.
لانه constriction قلنا الميديال بتكون faster than اللاترال. لكن شوف لما عملوا السترين, what did they found? They found that the lateral part has a lower strain. Yeah, بالسترين
So it's very more sensitive than
exactly. And it picks up patient of constriction earlier than the conventional hemodynamics will do. Yes. طيب. Now I get you back, or I get you into the most important part, which is this. The science, the echo signs of constriction. And in a big font, these are the three most important. And there are other less important signs. The three most important, the septal bounds. 1. 2, preserved or increased medial annular velocity compared to the lateral. ودي هنسميها من الآن onward annulus inversus, not annulus paradoxus. It is called annulus inversus. Or reversus is also right. Why we call it annulus inversus? لأنها it is the inverse of the physiology. The physiology is the lateral faster than the medial. In constriction, you have the opposite or the inverse, which is medial faster than lateral. And the hepatic diastolic flow reverse. These are the three. Now also we have plethoric IVC, we have mitral respiratory flow variation, septal shutter, we might see a thick and calcified pericardium, we might have kind of constricted chamber seen morphologically, but these are less important signs. The three most important for constriction you should always be looking for are three: septal bounce, medial E prime velocity, hepatic diastolic flow reversal. Now, if you have, look at this important statement here, the presence of ventricular septal shift and either medial E prime velocity more than 9 or hepatic vein expiratory diastolic flow reversal ratio more than 0.79, this corresponds to sensitivity of 89 and specificity of 91 for the diagnosis. Yani if you have one septal bounce and then either this one or this one, the specificity is 91. Now, what about if you have the three of them? The three of them, the specificity is 97%. Okay, خلاص يعني انت if you have the three of them, that's kind of confirmed diagnosis of constriction. If you have septal bounce and one of these two, you have also high probability of 91, possibly 91% specificity of constriction. Okay, right. Now look here. Look at this heart. What are we seeing? You are seeing dilated atrium. Look at the septum. Focus on the septum. It's bouncing. Look at the LV and RV. They are constricted from outside. They are constricted and they become kind of wasted here. Yeah, there is chamber distortion. This is an extreme degree of constriction. So this is what you see morphologically. Most important is the septal bounce. Now we come here. Medial E prime is 15. Lateral E prime is 12. So what is this? Annulus inversus. Okay? Annulus inversus. So I have septal bounce, which is 1. 2, I have annulus inversus, which is 2. And third, look at the hepatic venous Doppler. During inspiration and during expiration. And you have just to compare this with this. This is the diastolic reversal. And you see, is it more in expiration or in inspiration, or it is fixed? You see that it is more during expiration. So increased expiratory flow reversal in the hepatic venous Doppler, the third sign of constriction. So these are the three signs of constriction in this case. Good. Now look here, focus. Focus on the septum. And again, you see that the chamber are elongated and compressed. The atria are dilated. Look at the septum. It's bouncing, bouncing. And here also, look at this septum and follow it for some time. By the way, when we talk about septal bounce, you cannot see it in 1 beat or 2 beats because it is respirophasic. Yani during inspiration, it goes leftward. During expiration, it goes rightward. So معناتها انت عشان to have 2 respiratory cycle, you need how many? You need 6 to 8 beats. Okay? عشان كده septal bounce, you better elongate your tracing to cover at least 10 beats عشان to catch it. Okay? عشان كده لاحظ هي ما بتجي على طول. 1 شوف مثلا هنا 1 1 2 3 4. See? جات مع البيتس number 4 septal bounce. Now, M mode is gonna show the septal bounce is even better than 2D. And this is again because we said over and over again that M mode is better than 2D in temporal resolution. Okay? That's why you see this wall excursion and the detail of wall excursion much better in M mode than in 2D. Look at the septal bounce. It goes this way and then this way, then this way, and then this way, and this way. So here, expiration, inspiration, expiration, inspiration. So during inspiration, it goes to the left. During expiration, it goes to the right. Okay? This is septal bounce. طيب. طيب يا شباب دي important, very important piece of information I would like to deliver to you. طبعا نحن in Sudan, like in so many other countries, COPD is relatively common. COPD can show septal bounce. Can you see septal bounce in COPD? Yes or no? Hey شباب, can you see septal bounce in COPD? Hey شباب?
لا ميكانيزم وايز لو اللي تكون حاجه اوت اوف ستاندرد
لانه السي او بي دي فيه exaggerated respiratory filling فيو can see septal bounce في السي او بي دي. So we can see septal bounce in COPD. Can we see plethoric IVC in COPD? Yes, we can. Can we see exaggerated mitral and tricuspid respirophasic changes? Yes, we can. يبقى it looks like constriction. لكن تخيل أنك أنت based on these echohemodynamics you diagnose constriction in a patient of COPD. شوف الكوست ممكن يكون إيش؟ الكوست ممكن إنه يكون cardiac irrelevant cardiac surgery. ولذلك you have to make sure أنه this patient is not showing these hemodynamic changes because of COPD. And simply what we do is you just go to the SVC. Go for SVC. يعني مثلا هنا لاحظوا معايا يا شباب. This is COPD. لاحظ في COPD respirophasic changes زي اللي موجودة في الكونستريكشن. During inspiration the mitral مثلا. During an inspiration it decreases. During expiration it increases. And there is septal bounce. يبقى بتشبه الكونستريكشن في حاجات كثيرة. اوكي لكن عشان اميز بيناتهم I go to the SVC. SVC not IVC. How can I get the SVC? Look here. In the subcostal, this is the SVC. This is the IVC. صح كده يا شباب? This is the IVC. تمام? The SVC is this one. So from the same window with the special tilt, you get the SVC. And you do interrogation of this one by PW. And here is what you get. This is the IVC signal in COPD an IVC signal in constriction. What is the difference يا شباب? What is the difference you observe? The most important difference between COPD and constriction is the forward flow. Look at the below the baseline. Here, during inspiration, it increases a lot. During expiration, it decreases a lot. But look at constriction. It's kind of fixed during inspiration and expiration. So the forward flow from the SVC into the right atrium is fixed in constrictive pericarditis. لكنه it is exaggerated changes during inspiration and expiration in COPD. يبقى عشان تميز بيناتهم you go to the IVC the way we described and you interrogate the forward flow. If there is accentuated changes of the forward flow between inspiration and expiration, this is COPD. Okay? This is important. So this is annulus reversus. Again, medial E prime velocity is here, lateral E prime velocity is here. So please repeat. يعني كده secretly كده أو silently annulus reversus. Annulus reversus. Annulus reversus. خلاص؟ Annulus reversus, medial E prime faster than the lateral E prime, one specific sign of constriction. طيب what is annulus paradoxus? Annulus paradoxus. يعني يا اخوانا مرات تلاحظوا انه الكارديولوجي confusing. Annulus reversus, annulus paradoxus, pulsus paradoxus. What is this? عشان كده انا بقول لك repeat it عشان just to digest it so well. And these terminologies are really so confusing. So confusing. And then I excuse our fellows of making a lot of confusion between all of them. يعني مشكلة حقيقية يعني. طيب الانيولس paradoxus is what? Annulus paradoxus. The paradoxical, the transmitral flow velocity to the mitral annular velocity ratio is inversely proportional to the pulmonary capillary wedge pressure in patient with constrictive pericarditis. حقيقة هل في أي واحد فيكم فهم الستيتمنت دي؟ في حد فهمها؟
دي دايره خيال واسع يا ابو.
صحيح؟ you're right. طيب ياسين بس أذكرك حاجة. الpulmonary capillary wedge pressure is reflected in echo by which sign? E over E prime. Sorry. E over E prime ratio. مذكرين ديا E over E prime. So as E increases and as E prime decreases, the pulmonary capillary wedge increases. يبقى مع كل ما الريشيو يزيد كل ما الpulmonary capillary wedge pressure يزيد. يبقى relation between E over E prime ratio and the pulmonary capillary wedge is what is direct proportional relationship. لكن in constriction it becomes the opposite. As the pulmonary capillary wedge pressure goes up, the ratio goes down. غريبة. ليه؟ لأنه إذا pulmonary capillary wedge goes high due to constriction معناته constriction ماله is advanced. If the constriction is advanced هيعمل إيش للإي برايم؟ هيعمل إيش للإي برايم؟ الميديال إي برايم، الميديال إي برايم هيعمل لها إيش؟ هيزيد الإي برايم. very good. هيزيد. يبقى الريشيو هيحصل له إيش؟
ريفيرس.
it decreases. exactly. شفت كيف الفرق؟ يبقى ال E over E prime ratio reflects the pulmonary capillary wedge in a direct proportional relationship في conditions كثيرة إلا الكونستريكشن. في الكونستريكشن كل ما البلمونري كابيلاري ويدج بريشر زاد كل ما الريشيو نقص. And this is called annulus paradoxus. يعني هنا مثلا يا شباب this is E over E prime and this is the capillary wedge pressure. As E over E prime ratio increases, that means the pulmonary capillary wedge pressure increases. أو العكس يعني. As the pulmonary capillary pressure increases, the E over E prime increases. لكن look at constriction, exactly the opposite. When the pulmonary capillary wedge pressure increases, the ratio decreases. This is called annulus paradoxus. Okay يا شباب؟ طيب. يبقى what is our diagnostic algorithm of constriction? If you look here, the diagnosis by echo, in the vast majority of cases, if echo fails to settle the diagnosis, you may go for cardiac cath. But if echo settle the diagnosis, then you start treatment. And the treatment for chronic constrictive pericarditis is complete surgical pericardial stripping. And remember, this is not an easy surgery. The operative mortality in the best hands is more than 6%. It's not easy surgery.
Okay.
Not as easy as it sounds. Pericardial stripping, just remove the pericardium. No, it's tough surgery. And this is cath. If you go for cath, that's what you are going to find in constriction. You are going to find what? Discordance between the LV and RV pressure. So as LV pressure goes up, the RV pressure goes down. And as LV pressure goes down, RV pressure goes up. Here, مثلا, look here. It goes down, the LV pressure. Look at the RV pressure. It goes up. When the LV pressure goes up, the RV pressure goes down. This is called discordance. Okay? Pressure discordance between the RV and the LV. While in restrictive cardiomyopathy, LV goes up, RV goes up. LV goes down, RV goes down. This is called concordance. Pressure concordance between the two chambers. So concordance is restrictive, discordance is constrictive. Now this slide is important. So look here. Precardial constriction and restrictive cardiomyopathy. This is a source of so many questions, by the way. That's why I want you to focus here. Pulmonary congestion is usually absent in constrictive pericarditis. Constrictive pericarditis is basically a disease of the right side. So you have an asarca, you have ascites, JVP elevated, but usually no pulmonary congestion. While in restrictive, it hits the lungs. JVP, you are going to demonstrate prominent wide descending constriction and precordial knock. Okay? Now, when we come to the texture of the myocardium, is going to be normal in precardial, like it might be sparkling or different kind of textures, hypertrophy, stuff like that. Atrial size is larger in restrictive than in constrictive. Okay? So the atria dilates more significantly in restrictive cardiomyopathy than in constrictive pericarditis. Okay? Respiratory variation is constriction sign. Mitral annular diastolic velocity, and by that we mean E prime of the medial annulus is more than 8 in constriction and less than 8 in cardiomyopathy. Now, natriuretic peptide, B-type natriuretic peptide, tends to be higher in restriction than in constriction. يعني ال PMP and Pro PMP يا شباب بتكون higher في restrictive cardiomyopathy than in constrictive pericarditis. لأنه في الconstrictive هي أصلا is a marker of what? Stretch. The marker of stretch ال PMP Pro PMP. So are you expecting the stretch to be more in constrictive pericarditis ولا in restrictive cardiomyopathy? For sure in restrictive cardiomyopathy. طيب. The pulmonary artery systolic pressure is expected to be higher in restrictive than in constrictive. And one important sign also here, the equalization of the diastolic pressure between the two chambers, right and left, okay, is present in the pericardial constriction more than in restrictive cardiomyopathy. So أهم حاجات هنا اللي هي source of questions يا شباب هي إنه lung congestion is not a sign of pericardial constriction. The atria are larger in restrictive than constrictive. The medial E prime velocity is faster in constriction than in restriction. The pro-PNB is higher in restrictive than constrictive. The pulmonary artery pressure is higher in restrictive than in constrictive. Okay, شباب? And this is مثلا the pro-PNB in constrictive pericarditis هنا and restrictive cardiomyopathy, and see the comparison. In restrictive, it tends to be kind of normal and low or slightly high, but in restrictive is much higher. طيب طيب يا شباب. This is the hepatic venous Doppler. طيب يا شباب, assure me that you are still following. لأنه this is the last part. This is the last part.
Yes, sir.
Okay. معايا يا شباب؟
Yes, yes, boss.
طيب, the last part there, I want you to focus here. And I might have gone so deep into this topic, again, because I know you are smart and this is covers everything you need to know about pericardial disease. عشان كده we have gone so deeply into this. This is the hepatic venous Doppler. Okay? Hepatic venous Doppler. A normal hepatic venous Doppler فيه two forward flow, which are these, and two backward flow, which are these. How are these generated, يا شباب? How are they generated? Okay? How are they generated? أنا هنا I brought you from CardioServe a different schematics to explain it thoroughly so you understand it well and you know exactly what happens in the hepatic venous Doppler in all conditions. Okay? طيب. نبدأ ب this one. Okay? أول حاجة, what about the S? How is this S generated? This is the liver and this is the right side of the heart, right atrium and right ventricle. During RV systole, the right atrium is what? The right atrium is relaxing and filling with blood. So the blood comes from the liver into the right atrium, and this is the S. طيب, towards the end of systole, there is overfilling and there is ascent of the annulus. The annulus jumps upward and this pushes blood a little bit backward. This is V. Now, the mitral valve, the tricuspid valve opens and this takes blood down to the LV, and also blood comes from the liver to fill the right atrium. This is D. Now there is atrial contraction, and with atrial contraction, the majority of the blood moves into the RV, but a little bit moves back into the liver. This is A. Yes? So this is S, V, D, and A. the hepatic venous Doppler. Okay. يبقى الآن if I have this one, look at this one. This is inspiration. This part is inspiration. And this one is expiration. Inspiration and expiration. This is what? S. This is, sorry, S. And this is V. This is D. And this is A. This is A. Again, this is S. This is V. This is D. And this is what? A. تمام؟ طيب. This is what? This is S. This is D. And this is A. تمام؟ طيب, I want you to compare A of the inspiration with the A of the expiration. Which one is more?
Expiration.
Exactly. Ahidi. This is the A of the inspiration. And this is A of the expiration. يبقى هنا what do I have? I have increased expiratory flow reversal in diastole. And this is constriction. This is constriction. تمام? Look at the restrictive cardiomyopathy. Look at the D. This is D. Sorry, look at the reversal. The reversal is this one. Compare this reversal with this one here. What are we seeing here? The reversal increased during what? Inspiration. More than during expiration. This is restrictive. While in constrictive, reversal during expiration is more than during inspiration. This is important sign to distinguish these two confusing or possibly conflated entities. طيب, what is this هنا? This is S, small s and large S, and then D, and then A. What is this? Anybody can guess? This is systolic reversal, and this is severe TR. Okay? So that's all. And in pulmonary hypertension, we have a high A, and that is fixed with, doesn't change with inspiration like in restrictive and constrictive. So this is what you need to know about. And this slide has summarized everything you need to know about hepatic venous Doppler. Restrictive is more of inspiratory flow reversal. Constrictive is more of expiratory flow reversal than inspiratory. Pulmonary hypertension is increased in the reversal, but fixed in inspiration and expiration. And in TR, you have systolic reversal. Systolic reversal. Last thing, this hepatic venous Doppler is suggestive of what? Constrictive pericarditis, restrictive cardiomyopathy, AV dissociation, tricuspid stenosis. لو لاحظتوا, it doesn't look like respiratory changes. And suddenly we have very high reversal. It comes like 1 and 2. And this is canon A wave of AV dissociation. If you look at the ECG, it is kind of complete heart block. And I think they are pacing spikes. So when the A contracts, or when the atrium contracts against a closed tricuspid valve, you have very high A wave, very high reversal back in the liver, represented by this high wave, which is canon A wave. And this is canon A wave. We can demonstrate it clinically. We used to see it clinically, but probably not anymore. طيب, last thing, this chest X-ray shows which of the following? Chest X-ray, this one. Features of pulmonary hypertension, features of complete precardial agenesis, ICD, or pulmonary congestion. This is ICD. No, it is not ICD. This is pacemaker. Because there are no coils, huh? There are no coils, ya shabab. So this is ICD. Type. The right answer here is, this is feature of complete precardial agenesis. And this is the morphology of chest X-ray in pericardial agenesis or congenital absence of the pericardium. And they call it what? It has a name, which is what? A Snoopy dog sign, a Snoopy sign, because it looks like a dog. The heart moves left and posterior, and the lung tissue goes here, and we lack the lateral border of the heart because now it's behind the sternum. So it looks like a Snoopy dog, and this is a feature of absent congenital. This is so pathognomonic of congenital absence of the pericardium. And the congenital absence of the pericardium, does it affect the lifespan? No, it doesn't. It doesn't. But it makes it hard for echo to be acquired. The chamber tends to be more dilated. The heart tends to move more excessively. And when you do CT or chest X-ray, the heart is going to be posterior and lateral. Okay? And we also have to remember that sometimes we have a partial absence of pericardium, not complete or global. Partial absence of pericardium is probably more symptomatic and more harmful than complete absence. ليه؟ لأنه ممكن يعمل herniation of part of the wall. يعني لو عندك كله absent ما مشكلة، لكن لو هنا موجود وهنا موجود وهنا absent, this part might be under less pressure and it can bulge out. And in so doing, it might kink the coronaries and lead to chest pain and arrhythmia, حتى sudden cardiac death. Okay? So thank you so much for your attention and participation. I'm gonna stop the recording here.
Dr. Hatim, thank you so much for this and digestive lecture really. For very confusing topic أعتقد لكل الناس restrictive and constrictive.
Yes, it is.
بس يا ريت لو ترجع لي سريع كده معلش يعني ال COPD versus constrictive في ال SVC.
في ال SVC. Okay, جدا. Sure.